is embracing the fear of the Lord as a guide to your path to holistic health. We would like to welcome you this evening to our third night. And if you've missed any of the events or the sessions prior to, please look on our Facebook or our website page and you'll be able to see our first night where we focused on primarily the path, the stewardship in health. Previous night, which is last week, we looked at pediatric or common childhood illnesses. And tonight we'll be focusing on intensive care unit information. So I can tell you tonight this is very befitting to talk a little bit about this topic considering what we are hearing today. Just before we get started, I just want to share some updated news. As you all know, we are a holistic church. We focus on physical, mental, and spiritual. And during the pandemic, we were heavily involved in the physical and, of course, the mental and the spiritual as well, because it was much needed. So one of the things that we would do here at Antioch is every week, every Wednesday, we would talk about the pandemic, the COVID numbers, how to keep our members and our community safe. And, of course, we always included prayer. Well, tonight, we want you to do the same thing. Unfortunately, there has been an uptick with the COVID pandemic. We're seeing not only our community at large, but also even some of our members who have been impacted by COVID. As you all know, some of those signs and symptoms will mimic a cold, but after really looking into the process, they identify that there is obviously COVID, and we've seen that on the news. So some of the things that we've encouraged members to do, and also the community, this is very important, we are encouraging you to, again, try to stay distant. We love to hug and give each other a warm welcome, but sometimes when you don't know what's going on with that person, or if you're not familiar with where that person has been, sometimes you want to ask or just kind of say, hey, how you doing? Give them that distance, social distance. But the other thing that we've encouraged you to do is wash your hands. This is not just for COVID. This is for all of the viruses and bacteria that's going on, making sure that when you are having close contact with that individual, remember COVID has actually that transfer with the touching of the hands and even airborne. So again, we want to make sure that you are washing your hands with hand sanitizer when you're walking in and out of buildings, when you're going to eat a meal. Make sure you take that time to wash your hand. And I encourage you to go to the restroom and wash your hand with soap and water, which would even be better. And then the other thing we're encouraging members to do and the community is to wear a mask. If you feel uncomfortable around individuals, or if you feel that you are uncomfortable, perhaps with having some type of poor immune system, you're obviously sick from other comorbidities, which are other diagnoses and diseases, or the fact that you just feel uncomfortable, it is okay to wear a mask. I've noticed some of our members have been wearing masks all throughout the year. And again, this is to keep yourself safe, and also others safe. We do have masks in our church. We'll be actually starting the process tonight. So if you feel uncomfortable, we have masks here. We are encouraging you to wipe your hands, maintain that social distance. And then the other thing, of course, if you feel ill, please do not come to church. We do have church online. Last but not least, we've been actually encouraging members that you can order or purchase a COVID test. They can be at your local drugstores, hospitals, urgent care, and also you can still order them online. I have asked members who have reached out to me to order some online, have them in your house for safety, perhaps maybe if you feel uncomfortable, or if you'd like to share that with someone who says they feel uncomfortable, you could do so. So let's go ahead and get started because we have a lot to hear. We are going to be hearing from Dr. Shepatel, who's going to be interviewed by Dr. Pullins. I'll let Dr. Pullins and Dr. Shepatel actually give their intros. But before we get started, I'd like to start with the moment of prayer. So if we can close our eyes, open our hearts. Heavenly Father, we thank you for allowing us once again to gather. We thank you for warning us for all of the concerns that many people have had and have today. We ask that you touch them, Heavenly Father. Give them the answer to any of the concerns, the illnesses, whether they are chronic or acute. We ask that you give them the information that's needed. And even if there's information that they can't think of today, that they can go back and listen to this message and be able to use it not only for their ability, but for their family members' ability. And thank you for technology, for allowing this information to not just go within our house, but outside our house, not within our community, but throughout the country. We want to thank you, Heavenly Father, for allowing us to be who we are to you, and that is your children. We thank you for giving us this blessing, and we thank you for the message today and all blessings. Amen.
Amen. Thank you, Dr. Allen, for that introduction and discussion about what's going on in the community. As health professionals, it's our responsibility and duty to make sure that you're informed on most up-to-date information. And so we're not here to do scare tactics. It's just to make you aware that COVID is here. And in some people, it is worse than a cold or a flu. So if you are in that high risk, you probably want to consider, avoiding big crowds, at least right now for the next couple of weeks, because this is probably going to last for a couple more weeks before we started to see a downtrend. So tonight we have a special guest from Mayo. This first 3 nights I've been able to, stay home each 3 nights. These are people that I work with, people that I respect. Dr. Shapatal is not only a physician, but she's also a leader at Mayo Clinic, and she's a leader of leaders. And so she hails, I believe you hail from the state of Michigan, because you did a lot of training in Michigan, yes. And we have some Michigan people in the house. So yes, she did a lot of her early training in Michigan, I think undergrad, medical school, residency, and then she went to Hawaii and did a fellowship in surgical intensive care, I believe. So she in MD and a PhD wasn't enough. She had to get an MBA and all these other things. So she runs one of the committees at Mayo Clinic that chairs like myself go to every year for a wish list. So we want extra staff, or we want this. And so that committee makes a decision on whether we get what we were requesting each year. So she is sought after. She probably also has a target on her back because of that. And I think this isn't your second year in that role.
Yes, it is.
So she is still finding her way there, but doing a great job. When it came time for me to consider being chair of the department, she was one that pushed me in the back and said, "You can do this. You're ready." So she's one, so I'm thankful, even as a friend, that she is there to support, and I can call her anytime I have questions about things going on at the enterprise level. So she is very heavily in mission work. She does a lot of work in Haiti. And even despite to what's going on in Haiti, she has still found a way to get over there, which we definitely keep her in prayer, because that is a dangerous mission to go over there, particularly in what's going on now. So we'll probably have her back. One thing I know that we do a lot of missions as well in Pakistan and India and in Uganda. But having someone that has that experience, particularly, I'm speaking to Dr. Allen, if we decide to expand on our medical branch of our missions, having someone like her to lean on it, to hear what works and what doesn't work when you're out in the field. So that's my introduction to her. One thing I'm going to ask her to speak on before we get into the whole ICU discussion is that she also, during the height of pandemic, she represented Mayo Clinic when it came to dealing with the influx of patients coming in for COVID-19. So she was like running the crisis part of the hospital, and she worked with Dignity Health and with Banner. around that time, there was a commercial going on where all three organizations came together. And if you watched those commercials, she was on that commercial. So she is definitely a giant by all means. And so I'm going to ask her to talk just a brief about how it was to try to run things in the midst of the pandemic and, not necessarily having all the resources you wanted and stuff like that. So I'll have you maybe start there first.
Well, good evening, everyone. I'm very honored to be here. And Dr. Pullins wasn't supposed to tell my mom I'm still sneaking down to Haiti, but now Mama knows. But we thank you for that introduction and all of those accolades. But those abbreviations behind my name are just because I am a forever student. I'm always learning. And so hopefully being here tonight, I will learn from you how to be better at my job through your questions, because I serve people. And I think that's what I've been called to do. And during the pandemic, I think the organizations, the healthcare organizations in this institution which serve people, decided that we could do it better together. And that was really a magical, wonderful thing. And I think that we led in the nation because we were really affected here. You guys were called during that time period. And that has led to us continuing to talk together and figure out what that looks like, because there's so many different ways that we can collaborate. And we meet even to this day once a month and share kind of what we're doing. And we have seen an uptick in COVID and other respiratory illnesses, and we've been able to pick it up because people are testing. So we have a higher level of sensitivity. When people feel ill, they're doing those tests and they're providing that information back to the government and back to the healthcare institutions, which is really important because then we are able to see the severity of the illness. The current strain, because these viruses continue to grow and mutate, is fairly contagious. So it is not as severe as it was previously, but it is contagious. But if you get COVID and your immune system is not able to fight it, then it becomes a very serious illness. And even if you have a low degree of COVID, just like if you get a cold or a common cold, it still affects your body. And you may have a low degree of COVID that is not as intense, and you may be a carrier, but if you're not practicing hand hygiene and all the beautiful things that I heard this evening, you can be a vector and cause someone else to have a severe disease. And so all of the basic things that we learned during COVID, wearing a mask if you have an illness, if you think it's just allergies, being respectful of those around you is really important. Hand hygiene, covering your mouth and nose when you cough, all of those things are just important habits to have. But testing is a way to provide more information to people. And we know that the tests are pretty sensitive, so I really appreciated you guys opening up with that.
Thank you, Dr. Charbonneau. We really want to get into this ICU discussion, and ICU was a major player during the COVID pandemic. I thought we should talk about that only because, I know that over the last year or so, we've had several members for various reasons go into the ICU. And if you've not been in ICU, to go there for the first time, it could be overwhelming. Just because there's so many moving parts, so many people coming in and out, there's tubes, there's monitors, there's beeping, there's so much going on. And so I thought it would be a good topic to discuss. And maybe there's, experience you've had in ICU and you never got that question answered. Why did they do this? Or why was that tube used or whatever? Dr. Shoptow works. You're not operating, you're just doing ICU work now, or are you still operating?
I stopped operating during COVID.
Okay.
Yeah.
So she's mainly doing ICU work now, and so this is what she does, and so no one better than her to come in and answer some questions today. So the first question is, what does it look like? What symptoms? What are the situations that require a patient to be even admitted to the ICU?
And that's an excellent question. So an intensive care unit, so ICU, is also known as a critical care unit. And individuals who are admitted into an intensive care unit or a critical care unit really are those folks who are requiring an intensive level of monitoring that can't be performed in a regular floor bed. And so the reason why intensive care units are so intimidating is because of all of the stuff that's in there. So the typical patients that get placed in an intensive care unit are those who are medically unstable, meaning from moment to moment, we don't know if the blood pressure is going to change, if the breathing is going to change, and we need to be able to interact very quickly. So folks who are medically unstable, there are people who are put in the intensive care unit who may be stable but require life support mechanisms like ventilators, so they have an escalated need for breathing, and those types of devices are in the intensive care unit. Or people who have an altered level of consciousness, so they're not awake, they can't talk or participate, they have had some sort of injury to their brain. And we also see people in the intensive care unit who have had like a surgical procedure or an intervention, and they need something very specific that requires a nurse that has been trained for that. So the nurses in the intensive care unit have a higher degree of training than other areas in the hospital.
Thank you. I think we have a picture of a typical ICU room, and so if you've been in one, this is typically, I think this is a Mayo Clinic ICU room, I believe, is it?
So this is one of many intensive care units, and it may look familiar if you've ever been in an intensive care unit. And one of the things that I think is very visible here is there are a lot of things in there, and it's scary, and you don't know what's happening in there. So intensive care units, the space, and we'll talk about the space and the equipment first, typically are larger rooms than the rest of a hospital. And so the intensive care units that we're building even now are bigger than this. So it's not unusual to have a larger footprint than what you see here. And one of the things that I want to point out, the reason why we're doing that is because when you see this, where's room for the nurse? Where's room for all of the other people that are supposed to be in this area caring for you or for your loved one? And then there's a key member of the care team that can't fit in when all of the other folks are there, and that's you and your family. And so the intensive care units that we have built and opened up this past year have a dedicated family zone in there, even with equipment, with beds in place so you can rest, which I think is a really, really important thing that the healthcare industry is now talking about in intensive care units, because it's a part of the healing process, and we'll get to that. But a large room with lots of locations to plug things in if the electricity comes out, goes off. So there's resiliency embedded legally in intensive care units, but a lot of equipment, scary equipment that beeps and makes noises. And so as we go on about questions you should ask, that might be one of them.
So these are just some of the things that you may see, not just in ICU, but even in your doctor's office. So can you talk a little bit about these slides here?
I kind of tried to categorize the equipment in the intensive care unit into 3 different areas. One being the non-invasive devices that you see that are used for monitoring. So the ones that can be placed externally without causing any degree of pain, and things that you may even see in your regular doctor's office. Things such as the finger that you see there is a pulse oximeter, devices to measure your oxygen level using light, monitors, EKG monitors that can measure your heart rhythm, the number of times that you breathe by the way your chest raises and goes up and down, and blood pressure cuffs. So those are devices that are monitoring. They don't provide any treatment, but they provide information. And so non-invasive monitors. And on the next slide, I have invasive type of monitors, and you may even see these not necessarily in the intensive care unit, because some of these items can be placed in external units, such as a regular medical floor. Some of them, as they get a little bit more intricate, and if you have more of them, are only placed in the intensive care unit, but catheters that can measure the amount of urine that you're making, devices that we put in major blood vessels to either monitor the way your heart is beating, how strong the heart is beating, but also can be used to infuse medications, and feeding tubes. That's another invasive device. And so when you put something in someone and you cross that natural barrier that protects you from infection, we try to do those types of invasive procedures in a very sterile monitor. So there's always risk and benefits, but they provide more information so we can treat patients. The third category of monitors and devices that we find in the intensive care unit are those devices that actually support organs. So they're alternatives to organs when organs are suffering or unable to do their job. And that's the next slide that I had. The organs that everybody became very, very familiar with failing were the lungs, respiratory failure. And so that's where we have ventilators that go in and support breathing when people are unable to breathe and they're unable to exchange oxygen. And so ventilators can be invasive, where the tube actually goes into the airway, the trachea. We can also do that by putting a mask on the face and pushing in a large amount of air, which is a little bit invasive of itself. And the other device is dialysis. So dialysis is very common, does not necessarily have to be performed in the intensive care unit, but that is an artificial kidney machine. And we have devices that can actually help the heart pump or replace the function of the heart in the intensive care unit these days, and those continue to evolve and evolve. One of the very important things to know about these devices is they don't actually treat the underlying organ failure. These are replacements for organ function. And these are the devices that we put in patients to give the body an opportunity to heal. Or sometimes we put these devices in as we're trying to understand what is going on with a patient, because that diagnostic journey sometimes takes time. We don't necessarily know. So there are a variety of other ones, and many of you may have had some experience with those.
Yeah, let's park there. I know there's people in the audience that have had either they've been in ICU or they have family members in ICU. So she went over a lot of lists of tubes, invasive, non-invasive type of monitoring. Let's open up to questions, maybe that your experience you've had or questions you have about what you've experienced or seen in ICU. Yes, we have a question. People get the mic up here. If we have a. And if there's questions that come online, if media team can let me know as well. Thank you.
On the ventilator and the trach, Mayo doesn't have a facility that they can place these patients in to get them off the ventilator and the trach. And the place that we went to was a dump. And not only me, many others have said the same thing. It was terrible. And I was so disappointed in that part of it. And he ended up coming back to Mayo because he pulled his trach out and they couldn't do anything with it, so they had to send him back to Mayo. That's the part that I don't understand, why Mayo does not have a facility that they can take care of their patients until they get off the ventilators and the trach. Because these places out here that they send them to, it's terrible.
So a couple things on that. I'm sorry that happened to you, and this will come up a little bit later on during this presentation regarding the journey of individuals who end up with respiratory failure and can't breathe on their own and need that support. And what does that mean if it's prolonged and you require support? What do we do when we have an endotracheal tube, and that is a tube that goes in the mouth into the trachea to get people better? We often say, because that's uncomfortable, we often ask if it's appropriate to transfer that directly into the trachea, out of the mouth, and do a surgical procedure so people can get up and mobilize and participate in physical therapy and have something outside of their mouth that's not as comfortable. So that's where you were talking about the tracheostomy tube. So it's just a different mechanism of delivering oxygen therapy and supporting the body. So once people get to the status where they are unable to be moved off the ventilator and they require prolonged ventilation, about a third of those patients that go to a long-term care facility that's able to take care of those patients as their body gets stronger, about a third of those patients are not ever able to transition off of the ventilator and require that ventilator and that tracheostomy for a prolonged period of time and for the rest of their life. At least in this state, and I would say probably in the United States, there are not a lot of facilities that can take care of those patients for a long period of time. And a lot of them closed down after COVID. as well. So we don't have access in this growing city to a lot of these organizations. On the good news side, we are in conversations with a couple of folks to say, hey, is this something that we can do as well? Because that's something more in the rehabilitation and the long-term care part of medicine. And should we be in that space as well? And so we are having conversations on that. But as of right now, we don't have that. And you can see the need for us to be able to move patients out of the hospital so we can also open up beds for newer patients, but only when people are ready. We have relationships with some of these companies, but we don't oversee these organizations. And so I'm sorry that you ended up back in our institution, and I'm glad you came back because that's what we're there for. So I don't know if that exactly answers your question, but I do understand what you've gone through.
If you say your question, I can repeat it.
Mm-hmm.
Do they check these facilities out that they send people, let people go to?
We do. There are a couple of people who do. One is we have case managers as we go over the team. Case managers, typically their background is in social work, or they have a nursing background, and they deal with the transition of care as patients go from unstable to stable. And so they do have an awareness of the capabilities of these organizations, and most have visited these organizations. But one of the most important thing, as everything we do is patient-centric, is that we ask patients and try to get feedback about their experience, because that's the most important. And then we start suggesting that perhaps, and we're not legally allowed to direct patients, but we start suggesting and provide information on our experience. So internally, we have an awareness of those, but we also always recommend that when people are being moved outside of our hospital to visit these locations. And there's more than just the ventilator hospital. There are rehabilitation hospitals to strengthen muscles. There's skilled nursing facilities as well as an intermediary step. And then the third person or component that looks at these organizations is our federal government, CMS. So these facilities have to meet some basic regulatory standards. And so it's always important, if you don't have the experience that you believe that you should have had, to report those organizations not only to them, because they have a right, they have to respond, but also to the people that they report to, so we can have a continual process of improvement.
So this is the kind of conversation we want to have, and this brings up a great point that when you have negative experiences, don't be silent. Sometimes you need to do it right in the heat of the moment, because if sometimes you wait, things happen and then it never happen. But always, when you're having those, just report that, because sometimes we don't know until, if people don't say anything, we won't know. And so even when I'm referring patients out to maybe specialists in the community, the list of specialists I use mainly come from either I personally know that specialist, or I have a long-standing relationship in the sense that my patients, one after another, have always come back and have never complained. And that's how we pick that. And so even we're picking ventilation place or stuff like that, if people are constantly saying, hey, you sent us to this and this is terrible, we hear that more than once, that reflects negatively on us as an organization. So we won't continue, we'll probably end that relationship. The one issue is that, as she said, there's a shortage. So that's the other limiting factor. It's not like you have multiple places you can pick, so sometimes you kind of get pigeonholed to sometimes big places. But at the same time, with Mayo's reputation, we can put pressure on those organizations if we're hearing this negative feedback to say, hey, we know you may be one of few, but you need to do better by us and by our patients. And so those are things that no matter what the situation is, you want to make sure that you don't fear retribution. You need to speak out and think out you're speaking for other people that you don't want to go through the same situation that may be coming after you as well. Elder Woody.
Yes, my question I have is, when somebody's in CCU or ICU, you might have the primary come in, you have the resident come in, you have vascular come in, and then you have the surgeon come in. How does the hierarchy go? Who calls the shots? Are you all meet in one room and don't come in together? Because one will come a half hour later, then a half hour later, and we don't know who to listen to. Mm-hmm. Everybody's speaking to you.
You must be reading our next slide. Because that was after we got done. Before we move to who all these people are, is there any other questions about the interventions that are used for monitoring patients while they're in the ICU? Yes, sir. Here, we got a question.
Dr. Chapatel, I certainly appreciate you being here this evening. My question had more to do with, because we're talking about the ICU, is there a difference in equipment between like emergency rooms and ICU, or are those terms synonymous?
That's an excellent question. You may find equipment in the emergency room that we utilize in the intensive care unit, but an emergency room exists to deal with an episode of care and then hand off that patient once they've stabilized them to wherever they may end up going into the hospital. So sometimes they can reverse a condition, fix that patient, and then send them home. Other times they need the highest level of care after they have intervened, and then send them to the intensive care unit. Timing is so critically important. And so they keep the equipment downstairs, like ventilators, and even we can bring dialysis machines down there, especially as the hospitals get bigger, because they want to get that person stabilized as quickly as possible. And so if we have that equipment downstairs, we can come, they always tend to be downstairs, but we can come there, the expertise, and assist them as needed, but they also have the training to put in these equipment, many of these equipment. But we have the training, the full staff, as we move on to the team members, to help maintain that equipment and titrate it. And titrate it meaning to get people off of that equipment as well. But they often have a lot of equipment down there as well for stabilization.
All right, who's running the show? That's the next question.
Who is it? Who is in charge? And so I will say that we have a model in our organization of team-based care delivery. And we feel that it is really important not to have just one person making all the decisions, because these decisions are very difficult. And not one person can know everything. And many of the other institutions ascribe to that philosophy as well. And so there'll be many different members of care teams in the ICU because patients are dynamic and they typically have multiple things going on with them. And there's little room for error. In our organization, we're very fortunate because the individuals in our institution aren't driving from hospital to hospital. They're all right within our facility. The leader of the team when a patient is in the intensive care unit is the critical care physician, the intensive care physician, and they can come from many backgrounds. You heard Dr. Pullen say that my background was trauma surgery, critical care. So I did additional training in that area, but there are also folks who have done internal medicine, pulmonary, and then critical care, anesthesia and critical care, emergency room and critical care, but folks are board certified in critical care medicine, and most units will have that critical care physician in the hospital 24 hours a day. Not the same one, but a team. So it takes multiple people to be there, so you can have someone there 24 hours a day, 7 days a week, 365 days a year. And it can't always be one person. And so that's the reason why the team members change. Underneath that individual, because they need to look at the body holistically, they typically have people who are also critically care trained, but can be in that room after they leave your room and go to the next patient's room and be able to put into place that plan that you had decided with that patient. And so you'll see that there are nurse practitioners, and these days nurse practitioners are doctorates of nurse practitioners. So these are folks who have had years of training and then did additional training in critical care. There are physician assistants that have done the same type of thing. They're typically master degrees plus additional critical care training, and they're extenders of the physician. So they collaborate and work underneath the license of the physician, but the decision making comes from that critical care physician. And they are highly knowledgeable as well. Of course, as we are a training organization, and many of the organizations that have critical care units always have trainers in there. There are resident physicians as well who also spend time learning the art of critical care medicine. They learn the science in school, but now they're learning the art of delivering that care. And so those folks are in the room, but they always get the information and the directions from that critical care physician. And there are nurses in the room. So the nursing ratio in the critical care unit is very different from a regular floor because patients are dynamic. So nurses in the ICU will typically have 1 or 2 patients tops. And sometimes, depending on how much equipment you have in the room, you may have 3 nurses to 1 patient. One person operating, the dialysis machine, one person helping with the multiple medications that are being delivered. And so you may see a lot of folks in that room. There are also respiratory therapists that have been trained on the breathing machines and how to titrate it and how to deliver it comfortably, because it's really important for that. So you don't feel like you're being, like someone's forcing you to breathe when you're waking up and getting better and ready to breathe. There are the case managers that we talked about. They're the physical therapists, the occupational therapists, because you need physical therapists even if you are in an obtunded, comatose state to move your legs and move your muscles. And then pharmacists, to make sure that the medications, all of those medications that are being provided are safe. Are they compatible? They can go together. And that's what they've trained, and many of those pharmacists have PhDs. So you have this army of people coming in, and what you'd like is for all of them to come in at the same time, discuss everything at the same time, and then leave at the same time. But it's not that easy, right? Because there are many patients who are dynamic, and so many times it's divide and conquer, but there's multiple times during the day that we have these huddles that we call huddles, where we sit there and communicate. And the communication is so very important because you need all of this information so people can put that together in a picture and say, where are we now and where are we going? And that's where it's really important when we get to the questions to know at what point does that occur. And then the other person that I forgot outside of this is the people are the specialists. So the cardiologists, perhaps the surgeon that came in and operated on that very specific organ and really, really knows that organ well. So those consultants typically are working during their day jobs in other places they might be operating, and so they typically may not be there when the rest of the team is there. And this is where it gets really confusing and complicated, because sometimes you hear something a little bit different than what someone told you earlier in the day when they came in and they said, you know, I feel comfortable where we are going. And that specialist comes in and says, you know, I see something that might be a little bit concerning. And so when you're in the intensive care unit, it's a rocky road. It's up and down. It's up and down. And so it can be a little bit alarming, and you don't know if those individuals are talking because that process happens outside of your room. And so, and you don't know who's standing in your room. Someone just came in and you're like, is that a nurse or a student? Is it a resident? Is it a cardiologist? And so what we've tried to do, and many organizations have, is to try to color code folks by the scrubs that they're wearing. And so, you know, this is something that I took off of the internet. It's not ours, but we have a color coding system in our organization where if somebody's walking in your room and they're wearing a green scrub, there's a sign on the door that says that's the respiratory therapist. So you're like, okay, that's not just some random person coming in the room touching the ventilator and they don't know what they're doing. That's the respiratory therapist. Or the laboratory person that's coming in to draw blood is wearing a different color. And that's I would say 1980, 1990 kind of stuff. But we are moving to the point where we have these monitors in our rooms, and we have radio frequency up in the walls, and we're putting badges on those radio frequency identification badges on our badges. So when you walk in the room, your screen's going to say, Dr. Shapatal, general surgeon, just walked in your room. So then you know, right? Because that's really important. Because sometimes people introduce themselves to you and they say, hey, I'm Dr. Shapatal. And you're like, who was that? What did you say? Shapatal. You know, and so you really want to know. And sometimes you're on a little bit of medications, you're not hearing correctly, but it's important to know who's in your room. But more important is for you to advocate for yourself or advocate for that loved one that you have sitting there to say, hi, who are you? And that's okay, to remind us to introduce ourselves.
I have a question here up front.
Excuse me. I had an experience just a few days ago where the specialist came in the room and spoke to the patient and said, I'm getting ready to take you up to surgery. I'm sending the anesthesiologist in. the process they go through before you go to surgery. Well, when the anesthesiologist came in and asked a few questions, all of a sudden, you're not going to surgery from the anesthesiologist. Can you explain how that happened, that the specialist said it was okay to move forward and go to surgery, but the anesthesiologist overruled them?
Yes, I can, even wearing my hat as a surgeon. But, I have additional skills because I did a critical care training as well. So when I was just a surgeon, I knew that area of expertise. So I looked at the imaging. I could see that you needed your appendix taken out, and I made a decision. I'm going to take you to surgery. It's important to take out that appendix. But the anesthesiologist is the individual who trained on keeping you safe, keeping you comfortable, and making an assessment if he or she could do that during that procedure. And so that individual may have ordered additional tests and looked at information through a different lens than that surgeon. And that individual may have made a decision that, what I'm seeing on this monitor, that heart wave monitor, for example, is letting me know the medication that I'm going to give this individual right now may not be the best thing to do. It may not be the best thing to put you under anesthesia right now, and we might need to meet a few more steps before we do that. And they may have made the opinion that they can't keep you safe during that procedure and may have held up your surgery. I'm just giving you this theoretically, but that's what I see happen. What potentially should happen if we did it better, and we are trying to enhance the way we communicate, because quite frankly, physicians still communicate on pagers, right? That's like 1980s technology. They're pretty reliable because, they're not subject to, towers and things like that. But what you would have liked to happen is that physician and that anesthesiologist had that conversation and said, hey, I'd like to take out that appendix. Will you evaluate this patient? And they look at that information, and then they made that decision together before they came in the room and talked to you. But sometimes the timing doesn't quite work out because the doctor went back to surgery and then they were waiting for the anesthesiologist to come in and make that decision. But that puts you through that roller coaster ride like I discussed. But we talk about this all the time. The number one thing that we need to ensure is that patient is top of mind. So can we think about things a little bit differently? Can we reimagine how we have those conversations and how we communicate so that patient doesn't have to go through the up and down when they're sick?
So there is no hierarchy of authority with a specialist physician versus a anesthesiologist?
No. And I don't think that you would want that. It should be, these types of decisions really should be done together in a team-based, integrated fashion, right? In the end, there could always be one person who's going to say, I'm going to do it anyways, I'm going to find another anesthesiologist. And those are the extreme cases, the very rare things. Or that surgeon may say, well, I feel that the risk outweigh the benefits right now, and maybe we need a different anesthesiologist with a different level of training who can keep you safe because I really need to do this. So those conversations sometimes take a little bit of time, but there isn't, even though there's one person who is the quarterback providing care involves the entire football team, right? You need everybody to do their position and do it well so you can have the outcome that you need, right?
Yeah, I'm going to, when we do pre-op in the outpatient clinic, I always try to tell patients on the front end, don't put all your eggs in a basket, because sometimes they've scheduled time off and everything. By the time they come and see me, say, hey, I'm having this surgery in a month. I need you to clear me. I've already taken my time off. And I always remind them that the reason why I'm doing a pre-op screening is to make sure that you're in the best condition you can for that surgery. So, because sometimes patients get mad at me when I don't clear them, because they've been saying, I've been waiting for this surgery all this time, and now you won't clear me for surgery. And that's because there's something we found that could potentially be a problem while they're on the operating table. And so I try to tell my patients in the front end that if everything goes good, then I'll clear you. But if I find something that needs further evaluation, then we can't clear you. And so setting that expectations in the front end is, I can think what you were talking about. So yeah, but it's disheartening when you get all the way to the hospital and you just find out. There could be some one-offs where you find something last minute on the EKG when they get there, but to get that point and then being told, well, now you're not having surgery, I can see how that can turn someone off. It's 8:01, so we have some important things I really want to make sure we get through. So we're gonna fast forward and stop. No questions for right now, but if you have any more, definitely let me know. So when you go to the ICU, you always know that versus if they're on a regular medical floor, there's many more things that you have to go through, and there's a list of who can come in the room, how many people can come in the room. It's totally different. So why is it so hard to visit your loved one or friend or family member when they're in the ICU?
So I'll first start with what you're legally able to do in this state. People cannot deny you the ability to see someone that you love in the intensive care unit. So every patient has the right to have someone in the room with them. And so there are times where we recommend that we don't have people in there, shift change, or when we're doing something that puts the patient in a vulnerable position, because most often sick patients aren't able to think logically and for themselves, and they're vulnerable and they need privacy. So oftentimes we will ask you, can you leave the room if we're putting in a catheter? Can you leave the room if we're doing something invasive that we want it to be sterile? And so those are the conversations that we like to have, because these vulnerable patients are at a higher risk for the spread of infection. So often during COVID, we would recommend that for your health, that it was not recommended for people to come into the room and then take potential disease exposure outside of the room. And if we do that, we try to do it where it's safely, putting you in the gear and everything. But the number one reason that we restrict visitation is to prevent the spread of infection. The other is it's a dynamic environment. You saw those, all of that equipment, and things can change very quickly. And so it's difficult to have 5 or 6 members in the room when you may need to run in there and put in a medication and do it very quickly. And also, people heal when they're sleeping. It's really important to maintain a quiet environment and let people sleep. You get a cold, you tell everybody, peace, I'm gonna go to my room and I'm gonna go to sleep, because the body needs to sleep. And family in there stimulates family, and so you don't want that to happen to you 24 hours a day where patients are doing that. And so people need less stimulation and they need less rest. And not only that family member, but the family member or the patient, the patient's next door. In the intensive care unit, one of the other things that I didn't show there is these are semi-private rooms. So by regulatory requirement, you don't have a closed door. The nurses need to be able to see what's going on, and so patients have less privacy. And so the other patients have less privacy that you're walking by. And so there's just more restrictions, and we try to narrow the number of people who are in the room. But by legal right, you do have the right to be in that room. The organization can restrict how many at a time, but having that conversation as to the why, because everybody's unique, is really important.
Let's talk about the critical care journey. We've kind of talked a little bit about this. I'm going to just have something to say because the next slide, I think, is where I really want to get to. So Dr. Chappatel put this mask on, put the oxygen mask first on yourself, which we've heard if you've ever been on a plane. And we talk about caregiver stress. And so it's so important that you take care of yourself. So when your family member's in the ICU, a lot of times you're spending every day in and out of the hospital. And I know with Mother Taylor, we talked about that. I used to tell her, are you making sure you're going home at the end of the night to get your rest? And she was good at doing that. She'd see Elder Taylor, but then she'd go home for night and come back the next day. So you got to take your breath and get some respite and some relaxation. Otherwise, you'll be up in the hospital too,
Exactly.
Not soon. So let's go to these questions here about the ICU. These are some stats, and I don't know if you just want to kind of briefly touch on those.
So it's really hard to give people exact numbers of what's going to happen because it happens. Someone you love ends up in the ICU, you roll up in there and you're like, what's going to happen? How long are they going to be in there? And it varies. It really, really depends on the reason why someone is in the intensive care unit. If it's after a surgical procedure, sometimes we can say with the surgical procedure, they'll be out of here in 2 days. If it's someone with an illness, we need to figure out what that illness is. We need to have multiple points in time to develop the trajectory. But the average length of stay in the intensive care unit nationwide is about 4 days. But for every day that a patient stays in the intensive care unit, on average, they're going to be in the hospital 1.5 days additional after that. And if someone's in the intensive care unit for 3 weeks, then the odds of surviving an ICU, independent survival, I want to say. Independent meaning that they're going to go home now from that really is low. It starts decreasing. And that's when we start talking about what's the next step? What's that going to look like? Are you able to care for this person at home? So those are the numbers that I try to talk about with patients as we go on throughout that stay. But it's very, very difficult for a physician, nurse practitioner, the nurse at the bedside to tell you what's going to happen. And that's what you want to know as soon as you're there, what's going to happen. But we just have numbers, we have probabilities, but we just don't always know the exact answer. So 80% of patients who are in the intensive care unit, once you're in the intensive care unit, this is a very, very serious time. We don't put people in the intensive care unit if we think that they're stable and that they're going to return home very quickly. And so part of that care team, and the reason why we have so many members of that care team is because we know what happens to survivors of critical illness. 80% of people, even if they're in the ICU for 4 days, will experience post-ICU syndrome. We call it PICS syndrome. And there's a lot of research and there's a lot of intervention now at trying to prevent what happens post-ICU. And we're even developing a program where the intensive care unit folks are reaching out to patients after they've been in the ICU. Muscle weakness is one of the number one issues. And I think I saw you have some numbers as well for patients who end up in the ICU. It's not normal to lie in bed all day. Your body doesn't do it. Not normal to sit in one position all day. You begin muscle loss within hours of lying in a bed, especially if you have a debilitating illness, especially if you have an infection. Your muscles start getting extremely weak. And that's why we try to get range of motion, at least if you're sleeping. Many people will have physical impairments from what they came into the ICU with. There's cognitive dysfunction. So even if somebody comes into the ICU not involving anything in the brain, the medications that we give, the inability to sleep, what has been happening to them can cause long-term memory issues, problem-solving issues, and this is the reason why I always put the oxygen on yourself first, because after the ICU, you can't have expended all of your energy and all of your mental energy and have gotten sick, because when that husband of yours comes home or that daughter of yours comes home, you're going to need to be at your best to help them through this process. And then there's a lot of post-traumatic stress and depression because these things have happened and the body remembers what they were like before they came in. And so we know that there's a lot of delirium and confusion and anxiety and mental health issues that need to be dealt with on top of the illness. And so these are the things that we think about when patients leave the ICU, and you have to have top of mind.
I think later this month or maybe next month, and Dr. Allen can correct me if I'm wrong, do we have a night on advanced planning coming? Okay, so this is gonna, we don't have to spend a lot of time on this, but we're going to talk about that because in the ICU setting, it is so key that you have your advanced planning in place. And I'm sure Dr. Shabatal can share some horror stories of cases she's had when people didn't have this advanced. I don't know if you want to touch on that.
Just the big picture is advanced care directives is a global category for many of the more specific directives that people have regarding their health care. So that includes having a medical power of attorney where you've named an individual or multiple individuals to help make decisions if you can't. And then there are many people who have living wills. There are living wills that are just basic. If I can't make decisions for myself and I have a life condition that is not going to result in survival, I want you to do this, to all the way to I don't want feeding tubes. My daddy says, if I have a condition and I can't play the drums in my church and I can't eat, then I don't want anything done. But there are very specific things that people put in their living will. But I can tell you that these are conversations that a lot of people don't want to have. And so it's also really hard to sit down with someone and say, let's sit down and make your living will, because it's difficult. It's difficult to think about these things. And so I'm glad you're having a session, but these directives don't have to be written down. They're helpful when they're written down and you have multiple brothers and sisters and other family members, but knowing the person that you are being asked to care for and knowing what they think is a good quality of life, and these are how you're going to direct your questions at what is important to the person that I am making decisions for. so then you can move forward. Because those documents often don't cover every scenario. What is important to us is not what is important to me is not necessarily important to Dr. Pullins, is not very important to Dr. Mom over there. But quality of life, what does that mean? It means something different to everyone. Quality of life can be, well, I have my memories. I need my memories to be able to enjoy the things that I want to do. Will I have a sense of purpose? Will I be able to go to church every Sunday and share and fellowship and be able to communicate? There are people who want to, and cultures that enjoy having meals together and conversation. And there are people who say, if I am not able to eat and fellowship with other people and I don't know what's happening, I'm living in a care home, that's not a good quality of life to me. Am I able to have relationships with the folks that I love? And there are people who say, I want to be self-sufficient. If I can't care for myself and I'm having everything being administered through me through tubes, that's not what I deem a quality of life. And there are no right answers here. And so that's where I start with these advanced health care directives, having these conversations about what is important to you. You know, how would you want me to answer that question if I was asked?
We asked some questions, and these are things I definitely wanted to go down the list of. So the first question is, we kind of talked about that one, so we can probably move on to the second. What are the best case and worst case scenarios that we should be thinking about when our family member, whoever is in ICU?
I really like this question because, you know, I've been an intensive care unit doctor for 20 years, and when I get asked about what's going to happen, I don't have the ability to predict what's going to happen. I can tell you in my years of experience and my knowledge of what's happened to many people, what has happened over time with a variety of people. And so if you ask me what's the best case scenario with the things that I am seeing right now, that's a better question. What's the best case scenario? And then what's the worst case scenario? So then you can go back to, okay, mom has these things that mom believes is a good quality of life, and let me try to put these things together. So the best case scenario, the worst case scenario. And another one is, what should I be thinking about? You know, what am I not asking you? And always bring something to write those questions down, because you can think of a lot of questions when you're at home. And then as soon as you call up, you know, your sister, they're going to ask you another question. You're like, I didn't ask that question. But write it down. So it's really important.
So you talked about the up and down, and I'm going to come back to you. You talk about the up and down nature of the ICU. So one day you hear that your family member is doing great. Mm-hmm. And then you get that call in the middle of the night, hey, we had to resuscitate them, or their pulse rate is all over the place, or whatever things. So what are signs that individuals should be looking for? Because, you know, sometimes when patients are obtunded or comatose, any little movement, family members, they move their fingers, or they open their eyes. What does that mean?
It's a great question. And this is one where it gets even more confusing with all those care team members in, because you get that one person who comes in and they're looking at that one parameter on that ventilator, and it's changed. The oxygen level changed from 60% to 50%. And they're like, your loved one's doing better. And then you get really excited because there's that one parameter that has gotten better to that one person. The next person comes in and says, you know, things aren't looking good from their perspective. And then you're like, what's going on? Everybody is telling me something different. And it becomes a little bit confusing. It's the big picture. It's the collation of all of those signs together. And that's where you need that leader who can put all of those things together and say, what do these little things mean in the big picture? So you want to be able to learn all of those machines and be able to make that interpretation yourself. It's hard for me to even do that. It takes me sometimes an hour and a half to go through all that information to understand if someone's doing better. And so you have to develop trust in the team that's taking care of your loved one. But in order to develop that trust, you have to be able to continually have that communication day to day, right? Trust is built. And so it's a good question. You pose that question, what should I be looking for? And they will tell you.
Dr. Allen had a question.
Yeah, more a question/comment. Thank you, Dr. Shepatel. I think one of the things that, as we also know that there's another question there, the audience, those who are in virtual land, I'm encouraging you to take a picture of these questions because these are very important questions that you may be thinking about. Not for yourself today, but it could be for a family member or friend that may ask you questions. Just today, Dr. Shepatel, I have a family member in Michigan, family/friend in Michigan, and her daughter's calling me to ask me these questions. One other thing that I would highly encourage individuals to do, if you have a healthcare professional in the family or a friend, because you can have increased anxiety during the time you're there, call them. Step aside, say, hey, she just reached out to me. She said, Mom's blood pressure is 90/60 and her heart rate is 89. And because I know her mother's history, I was able to calm her down and share with her what was going on. When she walked back in the room, she felt better. She was able to talk to the doctor and ask questions. So I want to just ask if we can just elaborate just a little bit on that. How should the family member actually reach out to others or have expectations from their family and friends when they do that?
Yep, use your network. Use the people that you trust and your support team to help you generate these questions, especially if they have a little bit of knowledge and experience in hospital settings and even outside of hospital settings, caring for someone who has gone through a critical care illness, just to get those questions. Don't be shy. We welcome those types of questions, even though, some folks are like, I'm not going to call. I'm not going to put that person on the phone with, my doctor friend from North Dakota or wherever people live. It's important. If it's important to you, then we should make the time for that. Sometimes we can't call them directly, but if you get that number and it is a HIPAA violation and, that's something that you believe is okay and we put it in there, happy to have conversations. What I often do, because the ICU is dynamic and we're taking care of 25 patients, we try to set a time so we know that person is going to be ready and you're going to have another person ready, so we can have a care conference to ask those questions that they're thinking of and you are not quite thinking of, so we can get them done. And that can happen, once a week if someone's there for a long period of time, or once a day. I don't know if that's quite what you were looking for.
Yeah, I think that here at Antioch, our people are spoiled. I tell them that every year. Because we have physicians, we have nurses, so that there's no excuse for anybody in this household not to have. And we open, they ask us many times, my such and such is what do you think about this? So I agree, don't be shy. Use the resource that we have here at Antioch. And then people outside of Antioch use us too. So, but again, that's part of our servanthood approach to medicine. That's why we went into medicine, help people, because I want my family, if I didn't have a physician in the family or someone I knew, I would want, if I knew someone, I'd hope they would be able to speak and help out. And so that's what we do here. One thing you mentioned about, you talked about there's the patients are intubated where we're doing dialysis, that we are just trying to replace what the body has already done and give it time to recover.
Yeah.
And you've also talked about how we are not the healer. God's given us wisdom on how to create a certain environment to give your body its own way to recover on its own. So can you talk a little bit about the body's ability to heal itself?
Yeah. The human body has a remarkable capacity to heal. The human body is extremely resilient, and you have to give it some time. And the body will tell you, and God will tell you, and whomever you believe in will tell you what the right thing to do is. Physicians, nurses, we don't heal. We're part of the support team, just like you. And so we give medications, we give the ventilators, we do the dialysis machines, and we do that in an effort to provide that body ammunition to fight the battle that it's going through, right? And so it's important to do all of the other things outside of science and that we're doing in the room, giving love, prayer, creating an environment of healing and positivity in that room to get that body to heal. And sometimes the decision is that it's not going to heal, but the body is just pretty amazing. But it's just, I get surprised by it all the time, and people recover from things that I didn't think that they would ever recover from. So you just have to be patient with the process. There are some things that I know in my 20 years that there are some devastating illnesses that occur. And we know that that function of the body will not heal through, the technology that we have put together. But those are the types of questions, like I said before, that are really important to help delineate. There are some things that we know, but there's a lot that we don't know. And so you have to be really patient with the process, patient with the body, patient with yourself. Give those providers some grace as well as you move forward. But it's just amazing to me how the human body is made and how resilient it is.
As we start closing up, I think you had some 3 takeaway points, which I'm going to bring up now if you want to just go down the list there.
And these are just general things. We talked about a lot of stuff. It's complex. This is a part of the intent of the hospital that not a lot of people choose to work in this environment because there's so much happening. There's so much going on. There's so much possibility for change. And the process is so complex. Sometimes we're talking about patients with brain issues, heart issues, kidney issues, skin issues, all of these things. And it's really hard for people to keep track of all of that. But know that if you hear about someone being in the intensive care unit, there was a decision made that this is complex. So you're walking into a complex situation and you need to be ready. You need to be ready mentally. You need to be ready for an emotional journey. You need to be ready intellectually. And sometimes you can't be ready, right? And that's where you rely on your family. Your given family, your chosen family, and your spiritual family. And then, like I've talked about being patient, be patient. Because sometimes people want you to make decisions right away. And if you're not ready to make a decision, that's okay. Give yourself some time, give the team some time. Don't feel pressured to make decisions. And be patient. Be patient with the process, be patient with all of what's happening, because I think that's really important. That will be good for you emotionally and physically, so you can be your best self for the person who's lying in that bed that you're caring for.
It's 8:30, so we were going to have questions, but I'm a stickler for time, and I believe in getting out at a certain time. So hopefully you enjoyed, you got some questions answered. We can probably stick around for another 5 minutes after if you have some questions that you personally want to ask one of us before we end. Again, I want to thank Dr. Allen for the introduction tonight. Also, Sister Cassandra and Sister Ebony, they also work at the door for us, so they're behind the scenes, but I definitely want to make sure I give a shout out to them. I appreciate helping us each night. What we will do, we will take our stand, we'll go down, and I'm going to ask our first assistant pastor, Elder Baker, if he would come up at this time and give us closing remarks, and he will end for us here. And we want to also thank Pastor Logan, who is on a sabbatical. This wouldn't be possible for him, and so continue to hold him up in prayer, and also Sister Logan as well. So thank you, sir.
Thank you. Come on, let's celebrate Dr. Pullins, amen, our health ministries team, Dr. Shah Patel, amen, for such a wonderful opportunity to, what's that? Thank you, yes. Such a wonderful opportunity. And did we not enjoy the information on tonight? I mean, such very heartfelt information. I really enjoyed the point. I had a fourth takeaway point, that there is still somewhere a beeper company that's in service. Doctors still carry pagers. That's incredible in 2024. That is something. We're all standing by way of announcements. We know that our men's weekend is upon us. The men, we will be out on Saturday, and then we're going to come back for fellowship on Sunday. So we want all the men and the women to come out and join us for such a wonderful celebration that we're going to have. Additionally, there will be no health series on next Wednesday, right? And there will be no Bible study on next Wednesday. If you come out here, you will be by yourself. All right, so next Wednesday, no health series, no Bible studies. That's going to be in recognition of the 4th of July holiday. I know that many will be traveling, things like that. Certainly appreciate the announcements that went out concerning masks and things like that. Take advantage of that. The church, we have supplies available. So when you come in, we're going to make a recommendation that if you so desire that you would wear a mask, wash your hands, sanitizers, things like that. We are very holistic in what we do, and we have made provisions for those that would like those different things that we have available to you. So take advantage of that. Remember to continue to keep all of our members in prayer, especially our pastor and first lady as they're traveling, and then everyone out there that's dealing with some type of illness, sickness, things like that, bereavement, other things. Let's just keep our body lifted up. With that, let's go to God in prayer. Our kind and gracious Father, we thank you so much for blessing us on this evening. Lord, it is you, God, Lord, that have given us wisdom, God. And Lord, you're even sharing your wisdom with us through individuals that come to us, Lord, by way of their expertise. And for that, God, we tell you thank you. Thank you, Lord, that we're able to learn, God, in an environment, Lord, that's not threatening, God, in an environment where we can ask questions, and we're in an environment, Lord, where we can get answers, Lord, to things that we have been pondering in our hearts. We ask, God, that you would continue to favor us in all that we do, God, as we seek, Lord, to live longer, God, Lord, such that we can serve you in a more acceptable way. We ask that you would continue to watch over, God, Lord, this house that we call Antioch. Continue to bless our members, Lord, our pastor, our first lady, Lord, all of the members of this church, God. We ask, God, Lord, that you would bless, Lord, those speakers that have come, God, Lord, to share their wisdom with us, and that you continue, God, Lord, to do what it is that you do in this world as we seek to please you and as we seek to serve you in a more better and acceptable way.
And all of God's children said, amen. Thank you so much for coming.